My name is Bryce. I'm going to be doing a presentation today on the reduction of CLABSI rates at Good Samaritan Hospital. This is for my capstone project for the bachelor course in nursing. We're going to scan the room to show you the participants, the audience. Okay, to get started, what is the current problem? This data is obviously a little bit outdated, according to one of the nurses in the room. There is an increase in central line-associated bloodstream infections. The current rate is 2.349, and the benchmark is 1. This was pulled off the Medicare.gov website. Obviously, there's a pretty big issue that needs to be addressed. So what is a central line-associated bloodstream infection? So a central line infection is an infection that is developed within 48 hours after a central line placement and has been confirmed in a lab. And why is the CLABSI rate elevated? So in my opinion, the CLABSI rate is elevated because there's a lack of compliance with the protocol. Good Samaritan has a CLABSI bundle in place that is evidence-based practice. So it is all up to date. There's evidence showing that the current practice is proven to work and reduce the rates. So how does a CLABSI affect the patient? So it prolongs hospital stays. Once someone develops a CLABSI, they have to go through an antibiotic treatment course of 14 days. Inflammation, it causes pain. Mortality, that can be caused by sepsis if we do not catch the CLABSI early enough. So I'm just going to say hang with me on these. Usually this is all about just interventions and what can fix the problem. But with my presentation, I go through like 3 studies that show that our current CLABSI bundle is picture perfect, and then the other 2 address the problem. So this one here, this one goes through education of port protectors to show that the Kuros caps do support and help with CLABSI rate. The purpose was to evaluate the use of educational interventions combined with core protectors and the correlation that it has against CLABSI rate. So the interventions were training the staff on CAPS cell recommendations. So that's basically just a flatline based recommendations that people will go to review and see if they need to implement anything or if their current practice is up to date. They did this on 85 participants. 25 were used education, just only education. The next were using education in Kuros caps. There was a 67% reduction in CLABSI rate with group 1, and there was 0 CLABSIs altogether in group 2. The next one is an implementation of a CLABSI bundle. So the interventions here, they put a CLABSI bundle that's kind of similar to ours. So they utilized hand hygiene, catheter site dressing, hub care, and a daily review of central necessity. This was done at a much bigger hospital than ours, 762-bed tertiary hospital in Korea. They found their data through pre and post rates. The pre-intervention, they measured central line days and patient days on these. So they did a 6, 9, 12, 36, and then 72-month recording. I just pulled the 9 and 36 because this here shows, if you read through the 9 and 36 months, it shows that compliance is lacking. That's where a lot of the problems come from. When the interventions are followed in the 9 months, there was only 3 CLABSIs recorded. But at 36 months, they stopped being compliant with the bundle, and there was 12 CLABSIs. This one here is your lovely CHG bathing. This uses step wedge cluster randomized trial to assess the compliance of nursing staff performing CLABSI interventions. So this one is going to be more directed on problem solving here. So they used educational outreach visits, auditing, and feedback implementations. This was done in the United States. Audits were done weekly, and the data obtained was during the months, 4 months after the month of May. So they did a total of 424 audits, and the post-intervention CLABSI rate was decreased by 27.4%. So on that last one, when they would audit, they would identify whether or not the CLABSI rate was going up or down, and then they would perform an educational intervention after. So depending month to month, if the auditing showed that the CLABSI rate was increasing and not going down, they would perform an educational intervention and then continue to audit to see if it improved. This one here is, PICC lines. They were looking at PICC lines here due to the fact that there was a 50% of CLABSIs were coming from PICC lines themselves. The introduction of an antimicrobial catheter and basic prevention strategies. We already utilize all this. This is just proving that our bundle is pretty perfect already. The experimental group here, they measured the antimicrobial PICC lines, and there was only 2 CLABSI events at the end of that. With using those antimicrobial catheters and the prevention strategies, they were able to decrease the CLABSI rate by 91.15%. On this one here, they wanted to see the effect that education, hand hygiene, and healthcare had on CLABSI rates. This one, this is going to go back to my intervention that I'm putting in, because it has an educational intervention and they had to pass the educational course with a 90% or better. If they failed, they must retake. This was done on 3 neurointensive care units. Catheter days were assessed, and the results showed that there was a decrease from 8.7 pre-intervention to 4.5 post-intervention on the CLABSI rate. So you guys should know this, but most of the people on my unit probably didn't really remember what PICO stood for, so I kind of put it up there. So my PICO question is, an adult geriatric patient admitted to an intensive care unit, how does continued education in CLABSI prevention bundle compliance compared to the current bundle of central venous catheters affect the facility's yearly CLABSI rate? So, as I said before, the current practice includes yearly education and focuses on how to perform prevention methods already set. We already have our CLABSI bundle in place. All those other studies reviewed before showed that the bundle is picture perfect and it should help prevent CLABSI rates. So I put down
Code Strong, LaSalle Behavioral Health. Code Strong, LaSalle Behavioral Health.
Maybe one more time.
Code Strong, LaSalle Behavioral Health.
Okay, so I put down here at the bottom, bad habits become routine. So the minute that we break our compliance, we usually just overlook it at that. And if you don't correct your bad habits, you'll just continuously do it. So that's for saying, many times people, I'll walk into rooms, Curos caps won't be on the lines. If PICC team isn't here, those dressings aren't getting changed. And then CHG bathing, I know a few nurses that do them, but if they do them, they still don't document it. So how can we correct this? Continued education and monthly auditing of patients with central lines. I would say that I would do the same thing as the study before, where I would audit weekly. You can get that done by one of the staff nurses. I imagine it'll probably be myself if we go through with this. But you audit weekly on your CLABSI care bundle and make sure that people are doing what they need to do, applying Curos to caps, changing dressings, and documenting CHG bathing. And then if the CLABSI rates fall underneath a certain amount, we need to implement an online educational session with a passing rate of 90% or better. So the recommendation for evidence-based practice. I chose the Iowa model of evidence-based practice because it's self-explanatory with this issue. I mean, we identified the clinical question, searching the literature we've already done 1 and 2, so now we have to critically appraise the evidence of whether or not it worked. That study did show that there was a decrease in CLABSI rates when you implemented that, the education and the auditing. So after that, I would give or take, say, keep a monitor of the CLABSI rate every month, and then weigh whether or not the interventions were effective or not by 6 months in. Because we don't see too many central lines all the time anyways. It's it's not like we have a 762-bed hospital. With how will the data be measured, I would look at reimbursed rates after 6 months. So, I have to go through these questions with you. So the first one is the intervention appropriate, feasible for the workplace?
Yes.
Put in here.
Yes.
I think it is. I mean, I don't think it would be too difficult to make an online education session. And then I myself probably audit every week. For the second one, how will the intervention positively or negatively impact the nurse's obligation to provide holistic, culturally sensitive, patient-centered care to the identified population of the patients? I mean, obviously, us as nurses, our job is to provide excellent care, so that just kind of answers this. If we do our job correctly, CLABSI rates should come down. What are the legal and ethical implications for nurses who will be implementing the intervention? So with this, currently, if someone developed a CLABSI, became septic, and died, they could probably pull the charts and find many flaws that would knock the nurses. So with implementing this and having everybody well educated on CLABSIs and how to prevent them and to provide the documentation, we might be able to avoid the legal aspect. How will implementing the intervention positively or negatively impact the interprofessional multidisciplinary team? Any clue?
Well, I think having that communication with the physicians when you were talking about like getting them out early and things like that, just having that continuing open conversation saying, hey, we don't really need this, can we go ahead and pull it, as part of the interventions to get them out as quickly as possible.
I also think that with everybody being well educated on PICC line dressings and such, we wouldn't have to rely so much on PICC teams to control the care of the central lines.
Yeah, good point.
Because we have a lot of new nurses. I mean, we aren't all as experienced. There used to be a lot of the experienced have left, and new nurses don't feel comfortable doing that.
Oh, could I add something?
Yeah, you can just jump.
I think it'll be interesting too if you can say that these are the things that we want to focus on, obviously like education, CHG, Kuros caps. Then you can bring it back whoever's having the issue, who was their preceptor, and did their preceptor then teach them? If not, do we have to then go back to the preceptor and educating them as well?
Right, yeah, that's good.
That is a good point. What is the workplace's process for implementing the intervention? Lovely, because my answer before was reach out to the education department. Can you put your input in there?
Well, I can help you and assist you in, if you're creating the PowerPoint for the knowledge piece of it, then, I mean, the education department can help you get that uploaded and get it to the right staff members that need to do it. And then, of course, helping to coordinate any kind of additional education that you would need.
What are the barriers to implementing this intervention? It's kind of the education's time. If you have the time to assist, that's my only intervention. Because otherwise, I would be offering to audit every week, and then basically it's just developing that online course. Who are the advocates to involve in implementing that intervention? I really think you guys would appreciate it, and I also think PICC team would appreciate it because they don't have to be so reliant on with every little aspect of the central line.
Yeah, I think the staff nurses too, if they're not fully aware of, what the protocol looks like, that this education will help them be more aware and put it in the forefront when they are dealing with the central line.
Okay, and I think that's it. Did I hit my 7 minutes?
Oh yeah.